In this video, you can learn about congenital adrenal hyperplasia, its causes, clinical manifestations, treatment, and so on. Congenital adrenal hyperplasia, CAH, encompasses a group of autosomal recessive disorders caused by mutations in genes encoding steroidogenic enzymes involved in glucocorticoid synthesis or in the cofactor enzyme, P450 oxidoreductase. Invariably, patients affected by CAH exhibit glucocorticoid deficiency. Depending on the exact step of enzymatic block, they may also have excess production of mineralocorticoids or deficient production of sex steroids. Each form of CAH is associated with a specific defective gene. The most common type, 95% of cases, involves the gene for 21-hydroxylase. About 5% of cases of CAH are due to defects in the gene encoding 11-beta-hydroxylase and consequent 11-beta-hydroxylase deficiency. Other, more rare forms of CAH are caused by mutations in genes encoding 3-beta-hydroxysteroid dehydrogenase, 17-alpha-hydroxylase/17, 20-lyase, steroidogenic acute regulatory protein, STAR, cytochrome P450 oxidoreductase, etc. Deficiency of 21-hydroxylase is the most common form of congenital adrenal hyperplasia and leads to impaired conversion of 17-hydroxyprogesterone to 11-deoxycortisol. Excess 17-hydroxyprogesterone is shunted away from cortisol synthesis towards androgen production. Due to decline in cortisol, there is subsequent lack of feedback which causes the hypothalamus to increase adrenocorticotropic hormone, ACTH, secretion by the anterior pituitary. This results in stimulation of the adrenal cortex and adrenal androgen overproduction, that is dehydroepiandrosterone, androstenedione. Also, ACTH has a trophic effect on adrenal cortex cells, causing adrenal cortisol hyperplasia. Depending on the residual enzyme activity, 21-hydroxylase deficiency can present as three distinct clinical syndromes of differing severity. They are classic salt wasting, classic non-salt wasting or simple virilizing, and non-classic or late onset. In the classic salt wasting type, there is a severe enzyme deficiency. At birth, females present have ambiguous genitalia that can range from complete fusion of the labioscrotal folds and a phallic urethra to clitoromegaly, partial fusion of the labioscrotal folds, or both. Males have normal genitalia. In the first few weeks of life, they usually present with life-threatening adrenal crisis, vomiting, hypotension, hyperkalemia, etc. In classic non-salt wasting or simple virilizing form, females may have ambiguous genitalia at birth. Females are usually identified later in childhood because of precocious pubic hair, clitoromegaly, or both, often accompanied by accelerated growth and skeletal maturation. Similarly, males present later in childhood with the early development of pubic hair, phallic enlargement, or both, accompanied by accelerated linear growth and advancement of skeletal maturation. In non-classic or late-onset form, there is a mild enzyme deficiency and appears in late childhood. School-aged children may have premature pubarch ad rapid growth, whereas adolescent or adult girls present with hirsutism, acne, oligomenorrhea, and/or infertility. CAH due to 17-alpha-hydroxylase deficiency prevents the conversion of progesterone to 17-hydroxyprogesterone, cortisol, and adrenal androgen production. In contrast to 21-hydroxylase deficiency, hypertension, and hypokalemia occurs with 17-alpha-hydroxylase deficiency due to increased mineralocorticoids. Females with 17-hydroxylase deficiency appear phenotypically female at birth but do not develop breasts or menstruate in adolescence. Males with steroidogenic acute regulatory, STAR, deficiency, classic 3-beta-hydroxysteroid dehydrogenase deficiency, or 17-hydroxylase deficiency generally have ambiguous genitalia or female genitalia. They may be raised as girls and seek medical attention later in life because of hypertension or a lack of breast development. Hyperpigmentation occurs in patients with deficiencies of enzyme activity involved in cortisol synthesis, may be subtle and is best observed in the genitalia and areolae. Diagnosis of congenital adrenal hyperplasia, CAH. The diagnosis of CAH depends on the demonstration of inadequate production of cortisol, aldosterone, or both in the presence of accumulation of excess concentrations of precursor hormones. In all forms of 21-hydroxylase deficiency, patients have increased 17-hydroxyprogesterone and androgen levels. Adrenal androgens, for example, dehydroepiandrosterone and androstenedione, undergo peripheral conversion to testosterone. 24-hour urinary 17-ketosteroid levels are also elevated. In salt-wasting forms of CAH, there are low serum aldosterone concentrations, hyponatremia, hyperkalemia, and elevated plasma renin activity, PRA, indicating hypovolemia, whereas in hypertensive forms of adrenal hyperplasia, i.e., 11-beta-hydroxylase deficiency and 17-alpha-hydroxylase deficiency, are associated with suppressed PRA and, often, hypokalemia. Imaging studies in CAH. CT scanning of the adrenal gland can help exclude bilateral adrenal hemorrhage in patients with signs of acute adrenal failure without ambiguous genitalia or other clues to adrenal hyperplasia. Pelvic ultrasonography may be performed in an infant with ambiguous genitalia to demonstrate a uterus or associated renal anomalies, which are sometimes found in other conditions that may result in ambiguous genitalia, for example, mixed gonadal dysgenesis, Dennis-Drash syndrome. A bone age study is useful in evaluating for advanced skeletal maturation in a child who develops precocious pubic hair, clitoromegaly, or accelerated linear growth. A karyotype is essential in an infant with ambiguous genitalia to establish the chromosomal sex. Similarly, genetic testing is essential for genetic counseling and prenatal diagnosis of adrenal hyperplasia. Management of CAH. Newborns with ambiguous genitalia should be closely observed for symptoms and signs of salt wasting while a diagnosis is being established. Electrolyte abnormalities generally take from a few days to 3 weeks to appear, but in mild forms of salt wasting adrenal hyperplasia, salt wasting may not become apparent until an illness stresses the child. Hydrocortisone is a good treatment option for the prevention of adrenal crisis, but longer-acting prednisolone may be needed to control androgen excess. In children, hydrocortisone is given in divided doses at 1 to 1.5 times the normal cortisol production rate, nearly 10 to 13 mg per meter square per day. In adults, if hydrocortisone does not suffice, intermediate-acting glucocorticoids, example, prednisone, may be given, using the lowest dose necessary to suppress excess androgen production. For achieving fertility, dexamethasone treatment may be required but should only be given for the shortest possible time period to limit adverse metabolic side effects. Biochemical monitoring should include androstenedione and testosterone, aiming for the normal sex-specific reference range. 17-hydroxyprogesterone is a useful marker of overtreatment, indicated by 17-hydroxyprogesterone levels within the normal range of healthy controls. Patients with dehydration, hyponatremia, or hyperkalemia and a possible salt-wasting form of CAH should receive an 4 bolus of isotonic sodium chloride solution, 20 ml per kg or 450 ml per m2, over the first hour, as needed, to restore intravascular volume and blood pressure. This may be repeated if the blood pressure remains low. Dextrose must be administered if the patient is hypoglycemic and must be included in the rehydration fluid after the bolus dose to prevent hypoglycemia. Stress-dose glucocorticoids should be given at double or triple the daily dose for surgery, acute illness, or severe trauma. In macronodular hyperplasia subsequent to long-standing ACTH excess, the nodular areas can develop autonomous adrenal androgen production and may be unresponsive to glucocorticoid treatment. Children with CAH usually receive mineralocorticoid and salt replacement. However, young adults with CAH should undergo reassessment of their mineralocorticoid reserve. Plasma renin should be regularly monitored and kept within the upper half of the normal reference range. Medication should be used judiciously during pregnancy and in symptomatic patients with non-classical CAH. Infants with ambiguous genitalia require surgical evaluation and, if needed, plans for corrective surgery. Thanks for watching. Hope you enjoyed learning. Stay tuned for the next video. Thank you.